Hey everybody, I'm Nina Crowley. I'm Seeka's Professional Affiliations and Education Manager, and I'm excited to have a special guest today on the podcast. It's Carly Burridge. She's a physician assistant, and she's a fellow of the Obesity Medicine Association. She's co-founder and president of the PAs in Obesity Medicine, and she serves as secretary on the board for the Illinois Obesity Society. Carly is the founder of Gaining Health, and that is her company where she offers resources, support, and coaching to clinicians who want to provide comprehensive, evidence-based obesity care to their patients. We're going to talk a good bit about that today. She's also host of the Gaining Health podcast. So today's episode is going to be a co-led and more of a conversation between the two of us about comprehensive obesity care. So Carly has authored numerous publications and clinical practice statements through the Obesity Medicine Association. She has one on body composition. I will link in our notes because it's a really great resource I think we all need to know about in this field. And right now she's working as an obesity specialist clinically at Ascension Medical Weight Loss Solutions, and that is in Westmont, Illinois. So I am excited to have Carly on also because she and I both have a background in obesity care. We started in a surgical, metabolic and surgical weight management program. And so we got to talking about some of the things we learned in that field that we really wanted to make sure we're all, kind of harnessing in this new age with medications, filling the gap in obesity care. For us, I think the conversation we're most interested in is sharing some of our shared background with bariatric surgery programs and how some of that things that we've learned over the years, that wisdom that we've gained, I think really has a place to apply in the medical space now with the medications. And I know we're both super passionate as a PA and a RD about the interdisciplinary care and a real comprehensive approach. And really, what does that mean?
Absolutely. Yeah. And I love that we kind of both share that background of starting out in metabolic and bariatric surgery, because I think that has given us such a good foundation for, what does comprehensive obesity care really look like? And, and I think especially like you mentioned, now that we have some of these medications that are really approaching bariatric surgery type outcomes, how can we make sure that patients are still receiving that comprehensive care for obesity outside of, just having the medication? And so, this is something that you and I talked about before we started recording, is there's oftentimes this notion that we hear online or from colleagues or from friends, from people that are not as ingrained in the field perhaps as we are, that it's kind of an either or, that it's, surgery or medication, or that it's medication or lifestyle. And I think we're very passionate, both of us, about making sure that it's not an either or conversation, but that's really an and both conversation.
Yes. And I think that applies in so many areas, the black and white thinking that we can tend to have, that cognitive tendency where we just, sort of push things into these two buckets. And I think for sure that's an easier way to think. And I think our media and our just kind of our way these days strengthens that, well, which one is it? I always think about this when it comes to, never to go to a dinner party and tell anyone that you're a dietitian, because you will get all sorts of questions, or maybe that you work in obesity care. I'm sure you can relate to that. But if you do admit that, and then you'll kind of automatically get that question, well, so what do you think is the, reason that we have an obesity epidemic? Is it that they don't ride their bikes to school anymore, or it's just the fast food? And, people will love to give kind of that sole response, or that, single reason, and kind of of course, a personal responsibility. They love to sort of slap that on and give it a black and white reason. And so I think the best thing that we can do is really push everyone into, the gray area, the nuances between, they're not just these two options. There's certainly not one explanation for the cause of obesity. And that trickles down too to our treatment options. I know that when we got in the field, one of the things we were talking about earlier is just how when bariatric surgery, I got into that in 2007, and I cringed at some of the stuff I used to say, but I remember really kind of thinking that for patients, this was the last ditch effort. I even have said that, and I hate that comment, especially how much I know how powerful language is. But that last ditch effort, you've tried everything else to get here. This is the end of the line, and how much pressure that would have put on folks to sort of do right. And it was very black and white. It was very all or nothing. And I think now we know, we know more so we can do better. But really looking at all of these as sort of a spectrum of care. It's fluid. It's not just surgery is the end. And of course, you're always going to have nutrition and behavior and physical activity involvement in that. But now even seeing where medication can come in before, during, after surgery. So it's not either or, though the media, I think, has not heard that message yet.
Yeah. And I also think it also speaks to the chronic nature of obesity, because I remember when I first got into the bariatric surgery field too. So this was, back in the around 2011, 2012. And there was starting to be more of a recognition that obesity is a chronic disease, but it was still kind of being talked about, like you said, like this is kind of either a last ditch effort, or like once you have this, like this will cure your obesity. And I don't think we were having the conversations as much yet. I think we were starting to have those conversations around that time of, bariatric surgery is a tool. It is not a cure. And obesity is a chronic disease. And even after you've had this surgery, you still have obesity, and there's still that possibility that your body will want to regain that weight. And there's still all the other elements, right, they're surrounding that may have caused that obesity in the first place that we haven't fixed with the surgery, right? And so at that time, if we're not talking about this as a chronic disease and patients do experience weight gain after they've had surgery, then they saw that as like the total, utter failure. Like, I have failed this, therefore there is no hope, and this idea of talking about failing a surgery, right? And I think the language, you talk so much about language and how important that is. And I totally agree with you. We don't talk about failure anymore now, right? Or we want to try to avoid. Some people still use those terms, but really talking about, people responding to a surgery versus non-responders, and then also talking about this as a chronic disease. So, people will likely still have to have treatment and follow-up, and that may not necessarily be another surgery or medications, but it might be, and certainly, the lifestyle components are going to need to be continued, and they're always going to kind of struggle with this. This is their journey for the rest of their lives. And so I think the language around that has changed a lot as well. Have you found that also kind of since the early days of bariatric surgery?
Yeah, and I think, I mean, just like you said, success and failure, that's one of the big, one of my big pet peeves, that we really don't want to be saying that, because it just has such an implication to someone on, how they're going to proceed with things that they do in their daily behavior, right? And so I think it's our responsibility in the healthcare, as the healthcare providers, to really, use the neutral language, use language that's not, putting the ethics on it, success and failure, because patients do that enough. They've internalized this bias enough. And I remember, one of the things I struggled with as a bariatric coordinator was really getting my program to have good follow-up. How do we fix this problem that we had of poor long-term follow-up? Because we know that if, the longer people go without their team, they may be struggling, they may be doing great. But, if they're out there and they are not coming back for their routine follow-up care, getting their labs checked, getting vitamin, kind of checking in on all of that, they might not be doing well. And the longer they're out there not doing well, the harder it's going to be to sort of get back when they're ready to get back in with their care team. And so I really think getting the language right and getting the culture right in the clinic so that people want to return is big. And I think that's part of, we'll talk about comprehensive care a lot, but I think that's a big component of it. There's a lot in what we're talking about in an individual visit with an individual patient, but a lot of it is just, are people wanting to come back? Do they feel comfortable coming back? Do they view their healthcare provider as this top-down authoritative figure that they don't want to disappoint? Have they used the language of success and failure so that the patient feels like, I'm coming back, I gained a little bit of weight, I didn't, I failed this. We really want to make sure that everybody on the team is, reassuring them that, you didn't fail this treatment. The treatment may not be working for you. And I do like the language of responder and non-responder, although as we're saying that, that's a little black and white too, right? But there's sort of more of a spectrum of, response to a certain treatment. And I think it's really important that we always make those parallels between obesity care and the other medical conditions, because it's so clear when you explain it from, hey, like nobody's feeling like they need a life intervention when their blood pressure medication's not working, right? No one even knows about that. You might need two, you might need three, you might change your diet. There's different treatment options that are available, acceptable, and no one has a opinion certainly on which blood pressure or which cholesterol medicine we're taking, right?
Right. Yeah. Yeah. And I love that example. I use the blood pressure example a lot when I'm talking about medications. When people ask about, well, how long do I need to take the medication? Right. So I'll often compare, well, somebody's taking a medication for blood pressure and it helps them get their blood pressure down. And then if they stop taking the medication, a lot of times what might happen? So I use that example a lot. But the example that I really used to like to use in surgery was back pain. So I actually was really passionate about having an educational class for patients before I ever even met with them one-on-one. And so I kind of talk about the pathophysiology of obesity in that intro class, talk about the multifactorial disease state of obesity, talk about appetite regulating hormones and when those aren't working correctly. But then I also talk about from the very, before I ever even, would meet with them face to face, is I would compare it to back pain, right? So if somebody has back pain and it's at the point where they feel like, they need to see somebody or they need to get some help. So you go to your medical team and then depending on, we do some studies, we find out like how severe is the pain, what's causing it. We might do some tests, we might do some, some imaging studies, different ways to find out like what's causing the back pain, right? And then there's different treatment modalities. Maybe physical therapy is really helpful for one person. Maybe somebody needs medications or injections and physical therapy. Some people might need surgery, right? Depending on what the nature of the back pain is, how severe. And so we use a whole, wide treatment approach to treat it. But that doesn't mean that it's always going to be gone, right? We know with back pain, sometimes it can come and go. And so if your back pain was brought under control, but then, you wake up one morning and it's back or it's starting to get worse again, you would pick up the phone and call your medical team who helped you get your back pain under control and say, hey, my back is starting to hurt again, and let's get you back into treatment. And then I say, when it comes to weight, a lot of times the first thing that people do is call to cancel their next follow-up appointment because they're so worried about the weight gain because they don't want to disappoint, like you said, or they feel like they're failing something. And so I would have this discussion from the very beginning, right? Like, just like if your back pain was coming back, you would reach out for help. That's when we're really here for you. We're super excited to, celebrate your successes with you, but it's especially when you're struggling that we want to be there for you. And there's no shame in any of this, So I would instill that from day one is if you're struggling, please pick up the phone and call us. We are here to help you. There's no judgment. We're just, we're on your side. So yeah, that's kind of the example that I would use.
Yeah, and that's such, to me, what that reminds me of is just in the programming that I did with our program and as the dietitian, we did so much, pre-surgery preparation and education to get people ready just for that new lifestyle. I think sometimes there would be almost too much and people would view that as it would kind of be a gatekeeping thing. Like, well, if you don't get this right, then how are you going to do well after surgery? And we know that you just kind of sometimes have to go through that portal, right? I always would compare that to having a baby. And whereas you can read all the books in the world and think you know everything, but you kind of got to go through that portal literally to figure out what it's all about. And then, this is how it works. So I would always sort of, I'm on the fence with being prepared for surgery versus demonstrating that you could do this without, because I think there is that feeling people had too of like, well, like, why don't you just do those things? And then, which ignores, of course, the disease state of obesity. But But in that sort of comprehensive educational component, I think that is what I'm not seeing as much of in the culture now. And so one of the things that we had talked about is the different options that we have now. So it's not just this well-established, surgical program where, it was very structured. You'd have your evaluations with each of the team members. They'd all get together. They'd talk about, do the benefits outweigh the risks? And then you'd kind of move forward with insurance approval. And that's a really long process, really complicated process for surgery. And so it's a little bit different with medication now, so we have similar access to care issues, similar, issues with prior authorization and insurance. And, but there are more and more options for people. And there's more and more people who could benefit, from the medical option. So there's got to be more programs and ways for them to get medication. And I think the comprehensive approach, it weighs on my mind a lot that we need to make sure that our medical patients, just like our surgical patients, are getting access to all of those components. Because just like it's not diet, exercise, behavior, or medication. That's a definite and it's layered on. And it may be, you may need a little medication to curb appetite or to be able to, get rid of some of that food noise that we're hearing people talking about more. And so I've found that people then they're able to access some of that education that they've had over the years. And they're starting from a place of, I know all this stuff. It's just been hard for me to put into practice. And so all of those components, I think, layer on to it's a both and approach. We need nutrition, behavior, movement experts to help people at all the stages, and not just be one or the other.
Yeah. Yeah, I totally agree with you. And like we talked about, we both saw what that looked like in a surgery program where there's, really good support, at least in most of the surgical programs. Of course, every program's different, but on a lot of the good centers, they're meeting with the dietitian, they're meeting with, the clinicians for usually 3 to 6 months before they even have surgery. And like you said, sometimes this can be a gatekeeping thing and it's an insurance issue. But if it's done well, you can really prepare patients well for some of the lifestyle changes. And I agree that there shouldn't be, sometimes there were requirements somebody had to lose X amount of weight or something like that before they could have surgery. And I agree with you there. That goes against the understanding of obesity as a disease. And if they could do this on their own, they wouldn't be where they are, right? So I agree that there's some limitations there, but at the same time, that support that the patient gets before surgery and then also after surgery from the dietitians, from the medical team, they're getting a lot of support around, their activity, and also on the mental health side, right? We know that there's at minimum the psychiatric evaluation, which, depending on how that's done, can also be a pro or a con. But at least having mental health professionals involved in the process and having somebody that patients who do need more assistance, more help with the mental health side, that they have somebody that they're connected to. So, there's so many good things, I think, about the bariatric surgery type structure. And now, like you said, we have these medications that are approaching bariatric surgery type outcomes, but oftentimes with none of that structure around it. And especially as we're seeing out, it used to be that it was primarily just obesity specialists or maybe endocrinologists that were writing for some of the anti-obesity medications. But with, the explosion of popularity over the last year or two with some of the new medications being that much more effective, we're now seeing patients who are approaching their primary cares and other clinicians who haven't had much, if any, training in obesity. And now they're being asked to write these prescriptions. And so I think what you and I both share is this concern that patients are not getting comprehensive support around that. We want to make sure that they're getting some kind of nutritional guidance, some guidance on physical activity, on the mental health side. But what does that look like, right? How can we create this comprehensive obesity care in all of these different types of medical settings, and also, considering the time constraints that a lot of clinicians have with their patients. So, what you and I were talking about is there's probably not one answer to this, right? There's not one solution and everybody needs to do this. But let's talk about, for each clinic, for each clinician, what are their options to make sure that the patients are receiving that type of comprehensive care, whether it's directly through that provider or whether that provider, partners with, other clinicians in their community, or online programs or community programs, or, some kind of way to make sure that patients are being offered that comprehensive care around those medications, and that it doesn't become like we so often see in medicine, where it's just writing the prescription and that's it, and we're not addressing the lifestyle factors.
And there's such a, I always remember kind of explaining to people, being a bariatric dietitian, people would have questions about surgery and, all of that sort of judgment and bias aside. I just remember feeling really uncomfortable about the gap between like what I would provide for someone who needed some nutrition counseling about, health in general, maybe a little bit about their weight, but then jumping over the majority of people who struggled with, excess adiposity at some level, all the way to the more severe who needed surgery to be able to lose, 80 to 100 or more pounds. And so I felt I've been very happy in the past, 15 years that we do have that gap, that gap of people that people look at, and say, oh, you're fine, you look good, right? Those are people who right now would be probably a candidate for medication for their health or for their comorbid conditions, and that they do have excess adiposity, which is, another part of that. How do we define that and look at that and stage where people are at with their disease process and what kind of resources they need? But yeah, from a comprehensive care approach, even just as you said, that education and that information up front, I wonder how many folks are getting that. Like, even just the obesity is a disease and it's not your fault conversation, they're probably not getting that in all of these different configurations of how people are getting medication these days. So yeah, I do think it is, again, our tendency to want there to be one answer. And okay, well, my clinic does it right. We do this, and come to us, we do it all. Well, that may work for some people. Some people may be able to do it in person. Some people might need, virtual care, and that might work for them. Groups versus individual. Some people might need very little surveillance or monitoring, and they may be able to do this, kind of in a more solo fashion. All the different layers of introverts and extroverts, right? And how we, interact with our healthcare providers and all of that. But, I do feel, as we discussed, that providers and people who are the prescribers do have a responsibility to sort of help the patient configure that in some way, shape, or form, right? It may not be offering it all in your exact office, but if you're the one prescribing them an effective medication, just like a surgeon, you would hopefully never see a bariatric surgeon provide surgery and then not have any aftercare, not have a staff to take care of, any of these things. So I do think there's a lot of lessons learned from that comprehensive approach that we had to the medical realm. And we're seeing so much more of it. I'm seeing so many more providers assembling teams that include dietitians, that include mental health, behavioral health, that include exercise physiology and physical therapists, any of these different, professionals who can help people, implement the recommendations. Because, I love our either or, both and kind of conversation here, because it's also not just, oh, you go do those behavior changes. Oh, go work on it. Like, here's your diet, throw a piece of paper at them, or here's a list of exercises to do. That is very black and white. And if you know anything about behavior change, you know that we don't just do what people tell us to do, right? If anybody's married or in a long-term relationship, you can't just tell someone what to do when they do it. And if you are effective at that, then good for you. Stay with that person. Right? But yeah, it's so much more than that. It's so complicated to do it long term, and we have ebbs and flows, like you said, it's not this straight line where it's like, "Oh, I'm on the med. I had the surgery. I'm following the plan," and it's like that forever because it's food. It's complicated. It's social. It's love, it's enjoyment, it's, all of these things. And for some people it is easier and more black and white, but for most people it's layers and layers of nuance.
Yeah. Yeah. And as you mentioned, we have to have some kind of, as prescribers, we are responsible that our patients are getting that support in some way, shape, or form. And that's why I really wanted to start Gaining Health when I started it a few years ago, because, we saw that, the field of obesity medicine was growing. There's more and more interest. And especially now with the new medications, I think there's a real opportunity, like you said, for obesity medicine to fill that gap between lifestyle changes and surgery. Like it really fills that gap in between. But it's super important that it's done correctly, in my opinion. I know you believe this too. It has to be evidence-based. It has to be compassionate. This could go one way or another, right? It could go, I think it can really revolutionize healthcare if we really treat obesity compassionate, evidence-based, comprehensive way, but how that is done really makes a big difference. So it's not a matter of all clinicians telling their patients that they need to lose weight if their BMI is over. You know what I mean? Like that's the wrong approach. And so, that's really why I started Gaining Health, to make sure that we can, have resources for clinicians to help educate their patients about the pathophysiology of obesity, that this is complex, it's not their fault, and that there are evidence-based treatment options. So having a lot of that patient education, how do we structure these programs, but then also that there's not a one-size-fits-all for clinics also, right? Because every clinic is different and what resources they have available, if you're in a rural area versus if you're associated with a large hospital system, like that's going to look very different. And so when I talk about, how to offer comprehensive obesity care to patients, it's not like some people are like, oh, is this like a turnkey program where, this is how it is. I tell you how to do your program and you just follow this. And I'm like, no, it's not, because to me, that doesn't work, because every clinician is different. Every practice is different. So it's really giving different ideas and different strategies for how this can work for you and your patients, and giving you different ideas about resources that are out there, and then creating a lot of the resources too, if you don't have some of those resources in place, so that you don't have to recreate the wheel. But again, it's just so important that, and I created something called the MEANS model, which stands for, medical treatment. So, that's talking about pathophysiology of obesity, also how do we assess patients with obesity from a medical point of view, also looking at, what labs do we order, and, which medications might be contributing to weight gain, and what options are there for treatment of obesity in terms of medications and also surgical treatments, right? And making sure that people get good education, evidence-based information around that. And then the E stands for emotional well-being, right? So it's mental health, but also other emotions, because we use, eating and other things are so tied to our emotional well-being, which includes relationships and, stress management and
Not
mental
just the
health
mental
as well.
health when that people think of, not just mental illness, right? It's
Exactly.
day-to-day emotions, feelings, behaviors, which everybody has.
Right. Exactly. And that's why I really called it emotional, not just mental health, because then people just think about like mental health disorders, right? Which obviously are a part of that, but not all of it. Yeah. And then we have the activity, nutrition, and sleep. And I think, those are all factors that we need to be asking our patients about, and they need to be addressed in some way, shape, or form, so.
What I like about your model too is that I think I was just talking about this recently about evidence-based practice. And so I think everybody loves to throw that term around and they really hone in on evidence. And so, evidence research, what does the data tell us? What is the percent weight loss that you can hope to lose? And, all of these sort of, data, research, evidence factors. But the real model of evidence-based practice is three things. It's the evidence, best available evidence. It's the provider experience and your intuition and your time over the years of caring for people and what works and what doesn't. And then it's the patient values. And I think those two factors are what, we really have to promote. I think everybody gets the evidence part, not everybody, but we focus so much on that. But I think, for what your program does is it's saying, okay, yes, I could provide you that manual, but again, nobody changes their behavior when you hand them here's what to do. If that worked, only one person would have the rights to that and they'd be super rich and none of us would be working. So it's got to be, how that support. It sounds like, you have a nice support system for other providers to throw ideas around of what works for each other. And that's important. Hey, I tried this and on paper, this looks good. But when you actually try to roll it out to my patient population, it just didn't work. And, I don't want you to have to go through that same 6 months of pain. Like, why don't you take kind of a page from my book and I can tell you what I've learned. And then the patient values. And that's, to me, that is really the most important, because you can have the perfect way to eat. You can have the best treatment. You can have whatever, but the person has to do, 98% of that work is self-management behaviors done in between doctor's office visits and healthcare provider interaction. And so that's this huge category of values and beliefs and history and worldview and culture and social economic status. All of that stuff dictates how likely they are going to be able to implement the recommendations or the information that they're getting from their team. So I think that part is so important, and why even when people come to you asking, hey, give me the turnkey program, or in my world, it was give me the meal plan. Okay, I can give you my meal plan, but it has, I used to always say, like, it has tofu on it. Like, do you like tofu? Oh no, I wouldn't eat that. Well, then like my meal plan's not going to work for you, right? So we've got to do this dance together. And I do think that's what makes it so rewarding when you're able to offer that to patients and you can see them thrive, but on their terms, for goals that they set for themselves. And they may seem weird or different or not the things we would set for them, but when they're meeting their own goals, that's self-determinism, and that's what's related to like long-term fulfillment and happiness. So it's really nice when that can align that way.
I totally agree. And it's so much about just individualizing that care. And I think that's what makes our field so much fun to be in. It can also make it somewhat challenging, especially for people who are new, who just want to know, like, just tell me, like, what medication should I prescribe? Or like, what's the best nutrition plan? Or what kind of exercise should I recommend for my patients? And, the answer is, there is no one answer, like you said. And it just, I remember when I was kind of new to the field, I wanted all of those answers, and I wanted it to all be like the best evidence, and the evidence says we should do this. But what you find out, and sometimes you find this out through experience, or sometimes, it helps to have somebody tell you this who's been through this. It's like, come to every visit with an open mind, and just ask your patients, what do they need from you? What are they struggling with? What's going well for them? Right. Also celebrating what they're doing well, and what they've accomplished, because so often patients will focus on the one time that they screwed up, quote unquote. Right. Or and so just, really being an open book, and not having a preconceived notion of what you think that patient might need at that visit, but really just being open and, and having that conversation with them.
It's just like, patients, I think, often come thinking or wanting a rigid, prescriptive, like, you're going to tell me what to eat and that's going to work for me, because they've tried and failed so many things, right, over the years. But the answer is, it depends. It depends on you. What do you like? What do you want? Like, it's that conversation. I think you're right. Providers are like that too. They're coming saying, well, there's got to be an answer, right? Like, that, what's the secret sauce to just telling people, do this? And I think it's a lovely answer to say, you don't need too many tools, other than, how do people change behavior and how do you work with humans? And we all, can kind of draw from our own experience of what works, and that you don't know what works for someone until you're in that relationship or until you're in a place where they trust you enough to experiment. And I love that idea of just that curiosity approach and an experiment. Like, we're going to try this, and you're going to come back and give me some feedback on, did that work, and did you like it, and is that something you can continue? And maybe it will be. And I think that whole approach is it it also makes it, I guess it makes it so that AI can't do our jobs, right? Eventually,
It's true. It's
we
true.
want to like write it in an algorithm, even for each other. So
Yeah.
we've got to sort of, figure it out for the person. And until people know themselves that well, I don't think there'll be a one size fits all approach, which is,
Yeah.
again, what makes it great, right? Like, what if
Yeah.
there were just one way to lose weight or one program out there, and you weren't on the side of owning it or doing it? Like, then what
Yeah.
options do you have?
Right.
Even
Yeah.
that way, I would say even that way with medication. I'm sure you see this a lot. Like, I love sort of listening to the obesity medicine providers who've been in the field for a long time, who are kind of like, hey guys, over here, like we've had medication for a long
For
time.
many
It's not
years. Yeah.
just the GLP-1 receptor agonists or the ones that everybody's hearing about. While they may be effective for the majority right now, there's others out there. And so it's important, again, to think about the people who don't have access to that treatment, don't have, can't continue on that for contraindications or whatever. We also want to be careful of our language so that they don't feel like there's only one way these
Hmm.
days to lose weight, or to
I
keep,
agree.
to reduce their excess adiposity. And, I think that's important, how we frame
Yeah.
it.
It's really important. And I oftentimes remind patients and also other providers that I talk to that, hey, yeah, some of these new medications, they may be great, but we've been using these other medications for a long time. And I've had patients had incredible success. And it's, and I tell patients that too. And sometimes it's a little bit of, trial and error. Let's see how this works for you. And then also I think when it comes to goal setting as well, this is also where I think this individualization is so important. And I think, we're obviously hearing a lot of discussions around BMI and the limitations of BMI. And I'm always talk to my patients about this. And because oftentimes, especially new patients, they want to know, like, well, what should my goal weight be? What should I weigh? Should I be at this magical BMI? Or, what do you think my weight should be? And so I often tell them, I'm like, you know what? Whatever weight you're at where you feel good, you can do everything that you want to do. You have good energy. You're not bothered by, like a lot of pain or have certain limitations due to your weight. And if your lab markers and your vitals are looking good and you feel good, that's our goal, is for you to feel good. And so, patients, they really appreciate hearing that too, that you're not just trying to put them in a box with, a number or something like that.
And we always say don't should all over yourself, right?
Exactly.
Because
Yeah.
that's such that black and white mentality of like,
Yeah.
there's a right way, there's a wrong way. You're the expert. You're going to tell me what to do. I'm going to do it, and we'll have success. It's just,
Yeah.
black and white after black and white decision there.
Yeah. And sometimes I worry about those patients who are like, just tell me what I'm really good at doing what people tell me to do. And if you give me a plan, I'm going to stick to 100%. And I'm always like, okay, we're going to talk about this because you're worrying me a little bit, because a lot of times it's those patients that are either all on or they're totally off, right? It's this black and white thinking. And so kind of reining them in and being like, okay, what is the goal here? The goal is, lifelong health and habits that you feel like you can continue for the rest of your life, that fit into your schedule, your day to day. Tell me about your day to day. Who lives with you? What does your day to day look like? What does your schedule look like? What are some of your barriers? And whatever plan we put together, we want it to be something that fits into all of that, and that's going to work well for you, right?
And they've probably had a story, or there's definitely a story around, why they're telling you too. Like, oh, I need to weigh this much. I need to lose
Uh-huh.
this many. Like, I think those are important things to explore. And honestly, for me, it's been a really nice it's been really nice to see our field moving away from weight and BMI as the only outcomes of interest to either stage obesity or to look at, progress towards a goal, because those numbers have a lot of psychological impact, and
Uh-huh.
when we can really dive into, well, where did that come from? Oh, well, you know, something with their mother from years and years ago, or someone told, there's a story behind that. And I think when we can give them other metrics, when we're looking at their other health conditions and getting off medications, I remember in bariatrics was one of the best.
Yeah.
Energy and like functional health things of
Yep.
being able to get on the ground and play with their grandkids, get on an airplane without feeling uncomfortable. And really, for me, the body composition has been a nice, I think, way to have different data that is behavioral focused, that does capture the individual, and it captures more nuance than just weight. And the more we
Absolutely.
focus on muscle health and looking at, gains in that area, I'm even seeing a lot of people stop focusing just on reducing that excess adiposity and focusing on, keeping that muscle mass as a priority, gaining when you can, and really having that be an additional metric. And that helps. I mean, that to me, there's a nice tie in to the behavioral functional, like more muscle health, stronger. Stronger means
Yes.
more able to do the things that you want to do. And then you can really get to people's core values, and that gets them excited to do the things they need to do day in and day out to keep their health at a priority.
Totally. Yes. And I love that you mentioned it's a different metric rather than just that number on the scale, which so many people tie so much value to that's, unnecessary. And honestly, that's been one of the biggest things, whenever I've started numerous programs from the ground up, many of them within bariatric surgery programs. And if they didn't have a body composition analysis scale, that was the first thing I did was I would write a proposal to get one because I believe so strongly in using that additional data. It's so educational for patients. They love to see it. It really helps them get away from that negative relationship with the scale and that number on the scale when they're seeing that, or sometimes even their weight's gone up, right? Especially as they're getting into the maintenance stages, if they're doing more resistance training and more active, and they see, oh my gosh, my muscle mass has actually gone up because of this resistance training. Now they're excited that the number on the scale is actually a little bit higher because they're seeing like, oh wow, all this work I've been doing is paying off. Or, we talk a lot about the prevention of muscle mass loss during that weight reduction phase and the importance of, appropriate nutrition and protein and being active to preserve that muscle mass. And it really speaks to a lot of patients. They really can see the importance of that. And especially, as we're meeting with some of our elderly patients as well, and they see that some of their other friends or family members have lost function and have gotten weaker, and they don't want that. Right. And so it just really reemphasizes we're talking about quality of life and health and strength and not just that number on the scale. So I totally agree with you.
And with so many, with so many female patients too, and like you said, aging, I mean, looking at the drop off in your lean mass as we get older. And I think it's complicated for women too, because there's sort of this, oh, we don't want to lift weights. We don't want to bulk up. There's a lot of that you kind of have to untie sometimes when you're talking to folks about that. But yeah, and I think, of course, we could tell people, just like people did the whole eat less, exercise more. I think there's people that are just, well, eat more protein and lift weights, right? Like that's kind of a version of that same black and white advice, which is not helpful. But when you can actually sort of tie their, like a patient before they're on medication, and you can look at, hey, look, yes, your body weight is higher. It puts you in this category. And maybe even your adiposity, your body fat is higher, but your muscle mass is really low. So if we're going to put you on a medication, we need to monitor that much more closely. We need to, maybe have you see a exercise or nutrition person more frequently. we need to focus on that in our visits. I'm going to bring you in more regularly than I would someone who's way over here with they've got plenty of muscle mass. And if they lose a little bit while they're losing body fat, we're not as worried about them. So I think it also helps to individualize, but then that person's going to take that a whole lot more seriously than you just giving blanket advice of like, well, got to keep up that protein, And so I think it's, well, how do I do that? And why do I do that? And the people who need to know that before they actually are able to invest their energy in making that change, it really connects the dots for them.
Yeah, it makes it real when there's something that they can see that this is a test that was done on them. You're not talking about generalities. Like, this is their numbers, their body composition that they're seeing. It makes a big difference. And I think it makes a big difference too in selecting therapy. We talked about, you said, yes, we have some of these new highly effective anti-obesity, these second or third generation anti-obesity medications. We've also had other medications that have been around for a long time. So as clinicians, how do we start to determine which medication might be the right fit for which patient? And I think body composition is really important there because, again, if you're just looking at BMI, that can really miss the picture, especially with, like you said, like somebody who has sarcopenic obesity, somebody who actually has a very low muscle mass. Well, the approach that you take with them might be very different. They might not be the person that you want to put on a really highly effective anti-obesity medication, and really drive down their appetite. So, again, I think it gives us so much more information. It helps us with clinical decision making. It really helps our patients. And just, again, as we keep talking about, like individualizing the care for each patient, which I think, ultimately is what all of this comes down to. Like you said, the patient values, what they think is important, what their goals are, and then also their individual medical factors and things like that.
And tracking and monitoring over time, right? Another one of these sort of, either or is it's not you take this therapy and you're done, or you just get refills for life and you don't come back. It's, you're constantly coming in and tweaking and adjusting and optimizing. And so I do feel like it also is a way, I really do like let's try an experiment, right? Like, let's try eating this way for 4 to 6 weeks and then come back and we can kind of, talk about that. How is that going? And do we see any change in some of those parameters that we're looking at with muscle mass or body fat or, whatever the metrics of choice are? Or, you might not want to exercise or do this physical activity, but we could try it and let's see how that goes. So I do feel like it gives providers another tool to be able to help show the patient in a really concrete way of the way that their behaviors are actually changing and that they actually are having an outcome. I think that's pretty exciting.
Absolutely. Yeah. Oh, Dina, I think we could probably talk about this for like hours.
Let's clear our calendars and keep talking.
I
But
know.
yeah, I really appreciate too, just, you having a program for providers that, does take into account all those components of evidence-based practice. And it's a support network for, obesity is a chronic relapsing condition, and it is hard for people who have it. And it's hard for people who treat it because there's no one way to do it and there's no answer. So I think having a support network for other healthcare providers is also really important. And I'm glad you're doing that.
Thank you. Yeah, it is really nice to be able to support each other in that way. I mean, I remember, starting so many programs kind of on my own with no other obesity specialists in my clinic or in my facility that were doing it, or even when I started my own business, right? Like, that whole process can be kind of lonely. And a lot of times we have questions and we want to reach out to somebody or to a community of people who may have similar questions or who are, going through similar things. And so I think our patients need that type of community and support to know that they're not alone in this process. And I think we as clinicians need it too. So I really like the community that we're building with Gaining Health and our membership. And thank you for everything that you do. I mean, the body composition stuff, as you know, is something I talk about so much on this podcast and something I feel so passionate about. So thank you for everything you do and the conversations you have and the important work that you're doing with behavior change and body composition, and everything that you're doing with Sika as well.
Yeah, well, thank you. So we'll continue this conversation at our meetings this year. I know there's some good ones coming up. I'm excited to see you and some of the others at those.
All right. Well, thanks so much, Nina. This has been a
You
joy.
too. Bye bye.